All right, welcome. I'm excited about today. So we're going to talk about updates to EMS stroke systems of care, and we're going to talk about van training. So the reason that we are talking about stroke, it's the #1 leading cause of disability in the United States and in the world. It's the 5th leading cause of death, but what occurs often with stroke is disability, right? So in the United States, about 800,000 people have a stroke each year. That's new stroke. The other piece which you utilize which is helped in the community, is recognition of stroke. So your Cincinnati, right, is your fast face, arm, speech time. And then we'll talk a little bit about treatment of stroke and how that plays into your important role in identifying that stroke patient. So just so you have, it's hard to see on that slide over there, but this is from the CDC. So this is the most current, so this is deaths in adults, patients age 35 and up. And I pulled 35 and up because in our region, we have almost as many stroke patients in the 45 to 65 age group as we do in the 65 to 85 group. So strokes do occur at younger ages. So the darker, right, so I don't know if you've heard this, stroke belt is a higher prevalence of stroke. So Stanislaus County is over here. And then this is 65 and up, right, so more strokes. So very important topic, burden in our community, right? So this is a picture showing, so there's a few levels of care of stroke. The reason that that there is a change in process for you is that there is now a comprehensive stroke center in the region. So Doctors Medical Center is a comprehensive stroke center. There's also primary stroke centers which aren't shown on this map. Memorial and Kaiser are primary stroke centers in our local region. The next closest comprehensive stroke centers are either if you go to Sacramento or the Bay Area, or all the way past down to LA. So this was taken from SNIS, and I like this because there's a system and there's an assessment for trauma and STEMI, right? So you assess the patient based on what's occurring with the patient, they go to X facility. With stroke, the goal is that we identify the most severe strokes, the strokes that need to go to a higher level of care, right? So that's what we're gonna focus on today, identifying which patients should be transported directly to a comprehensive stroke center. And then the reason that this is changing, so it's not that anyone met as a group and just said, I think this would be a great idea. This is based on evidence and literature, right? So this was actually released at the International Stroke Conference this year in 2020. And essentially, you have a copy of the policy there, but our Mountain Valley EMS policy matches this. So they updated, adding in a large vessel screening tool. Ideally, there's some time frames that we'll go through, but essentially doing that initial stroke scale and then the severity scale. So currently right now, if you get a call about a suspected stroke, you will always do the Cincinnati, right? So face, arm, speech, time last known well, okay? So some patients may call in symptoms started 2 days ago. The alert process will start, right? So this has been in place, is their time last known well, or they last known normal within 24 hours. Then you're gonna stroke alert the patient. So that's essentially the time window when we could potentially intervene on the patient. So always a Cincinnati, if it's time last known well within 24 hours, then you'll activate a stroke alert. So if you do the Cincinnati and it's negative, be routine, right? So there's no change to current process. If you do the Cincinnati and it's positive, then you're gonna do the van, and we'll go into detail about the van. So I'm just giving you kind of the 30,000 foot level. So Cincinnati, if it's negative, you're done. If it's positive, then you're gonna do the van scale. If the van is negative, then you would, same as you had before, you're gonna go to the nearest primary or comprehensive stroke center. So no changes if the van is negative. However, if you do the van and it's positive, you're gonna transport to a comprehensive stroke center. Okay, so there's some time frames and some other pieces to that, which I have up here, but essentially, if it's gonna take the patient out of the window for IV-TPA, then you will not bypass, because IV-TPA is still standard of care, okay? The on-scene time is important. We'll go through the van. It's very quick and easy to do, right? So the goal, just like it is with STEMI or some of the other pieces, is on-scene less than 15 minutes. So keeping that in mind with this. The other thing that I want to highlight is time last known well. That's very important that you know a time last known well, because all of the interventions are essentially based off of that time frame. So if I went to bed at 11, no symptoms, woke up at 5 a.m. and I can't move my right side, my time last known well is 11 o'clock last night, right? I was discovered at 5 a.m., but everything is based off of that time last known well. And it's very helpful that it's an actual date and time, not 3 hours ago, because then it would just, if I say 3 hours ago and you pass along it was 3 hours ago, it just adds on. So an actual time last known well was on this date at 8 a.m., right? So that's very helpful. And then you'll make sure to document VAN. I'll tell you on the receiving end for all the hospitals in our region, when you report a VAN, that will mean something. We know that this is going to be implemented in the field, right? So that we may modify some of the, if someone reports in, it's a VAN positive, that may, if we can clear the scanner or do X, Y, and Z beforehand. Okay, so I think that is my piece. So we're going to switch over to Dr. Taleb.
Okay, great. What I like to do is, instead of just going straight to the scale and how to do it, I like to go into a little bit of a background about, why we do it, the impact on patient care, some of the neuroanatomy, and then go from there. And then at the end, I have some case examples. All right. All right. So, being VAN certified, you can do this online, but I do think the face-to-face allows for questions as well as better explanation as well. But really, we're going to go through some basic neuroanatomy, talk about the two different types of ischemic stroke. Of course, there's hemorrhagic, a bleed, versus a clot. And there's two types of clots, a small clot or a big clot. And then how to do a VAN exam quickly, and then just understand the massive impact that getting this type of treatment can have. So section 1, why screen for LVOs? So one of the biggest reasons is it doubles the people that are functional. So anywhere from 20% up to 50%, anywhere from 15 to 30% is that are functional with only TPA. But if you do endovascular, it can go anywhere from 20 to 50% that are functional. And so it doubles the people that are functional if it's done within quick enough time. Another cool thing is thrombectomy for select patients. It's only 10 to 20% that would get this, but thrombectomy can be done up to 24 hours, which is kind of nice, okay? And then pre-notification really changes what we do, whether you bypass or not. Some counties are not, some are, and lots of places are going towards bypass because of how long transfers take, but identifying in the field is super important no matter what you do. And then using VAN has been proven to improve times. It's actually using any LVO screen, and if you do parallel processing. So I like to do this. Some of you guys have seen this before, but I like to compare it to what we spend billions on, which is PCI, going to the cath lab for ST elevation MIs. The number of people you need to treat to prevent MI, stroke, and death combined is 16.7 people, or 17 people to make one person better to avoid MI, stroke, or death. In comparison to TPA alone, TPA versus endovascular, the number of needs to treat is 3. Here's 4, here's like 6.5, and here's 5.5. And so you see how huge of a difference it is. And it's not just MI, stroke, or death. This is functioning independently. And here's giving TPA from 0 to 3 hours for having no symptoms. You need to treat about 5.5, 6 people, and for 3 to 4.5 hours. And as you see, the longer you go, the effect is less. So either way, we want to go as fast as possible. That's super important. Now, but people say, well, the trials showing endovascular between 6 to 24 hours, you needed to treat less people. Yes, but you had to basically screen 100 and only take 10 or 20 for thrombectomy. So the number you treat goes down as the time goes by, So if you get someone there within 3 hours, you might be able to treat 50% of them, right? If you bring in them within 24 hours, you may only be able to treat 10. So yes, we can help them up to 24 hours, but speed is still important. So why did I do this? Is because we did a study here called UPS, utilization of proper imaging or screening and stroke. And this was in 2016. I presented this at one of the meetings in 2017, but we looked, our primary stroke centers even screening for LVOs. Look at this, percent LVO screening, 0. CTA done on patients with NIHO scale greater than 6 or equal to 6. And that's the guideline since 2015, right? Everyone has to be screened for an LVO above 6, only 40%. 60% of people that should have been screened were not. Now let's see, CTA done within 1 to 2 hours, only 26% that were red, sorry. Then CTA read within 1 hour, only 8%. Transfer within 2 hours, only 15%. That means 85% of the transfers take longer than 2 hours. And that's why some places have elected for bypass. We didn't have enough comprehensive stroke centers, so we couldn't bypass everyone there. So what we did is we said, okay, let's screen in the field. And so this is why it's important. I want everyone to, I'll go back to that in a sec, but I want you guys to just think about it this way. You know how MI, myocardial infarction, we need an EKG, non-ST elevation gets medical treatment, ST elevation gets cath lab. We have to think of that the same way for stroke. LVO, large vessel occlusion, we need a screen. We confirm with the CTA in the hospital, but we need some sort of screen. Non-LVO TPA, LVO TPA, and neuro IR suite. This is the old model, which was used in lots of hospitals to get CT head, TPA decision, go back for CTA, get the read or look at it, then call neuro IR, and then finally the team comes in at 1.5 or 2 hours, right? This was the old model. But what we did is we said, no, let's do parallel processing. Let's make all decisions up front. If they're VAN positive, we're going to get CT, CTA of head and neck, page neuro IR, the transfer center, everything all at once. And we actually reduced our endovascular treatment time by 50% because we really cut it by an hour. And so this is what we did, and we published on using VAN. What they did in the West Valley is they used it just to transfer people faster. And they were actually able to help their TPA times as well. It went down from 56 to 35 minutes, 110 minutes to 91 minutes. And it's actually down to 70 minutes now on average. So, you know, screening is super important. It doesn't matter whether you bypass or not. You need to know from the field, hey, I think this is a massive stroke. I don't, because that'll allow to activate the entire system, whatever system you're using to basically parallel process or do two things at once. This is the same thing. This was from May of 2018. Based on the results of VAN, Banner Del Web, this data can be used across Arizona to serve as a scale to measure and improve the results of stroke alerts. And that's basically what we've been doing. And this is another place. This was in Florida, and they reduced their endovascular treatment time from 116 minutes down to 56 minutes. That's an hour saved, right? Yeah, that's 60, yeah, okay, yeah. So that's an hour saved. And so, again, it's important to identify these patients early. This is another one, Mark Albert's group out of the University of Connecticut. They did the same thing, and they basically used VAN to see who got CT angiogram or CT perfusion. It's where you inject dye, and basically it goes up to the brain and looks for clots, and that helped them as well. So section 2. So section 1, the important point is two things, right? We have to think about it as it has massive impact on people. It doubles the people that are functional, so we have to identify early. Identifying early has been proven, whether you bypass or not, to reduce the time to endovascular treatment as well as better outcome. Okay, and we have to think about it just like MI, non-ST elevation MI, ST elevation MI, the same thing, non-large vessel occlusion, large vessel occlusion. So section 2, a little bit of ischemic stroke types and neuroanatomy and where VAN came from and why it makes neuroanatomical sense. So there's really two types, non-LVO and LVO. So how do we tell the difference? It's clinical. Of course, we confirm with imaging, but initially it's clinical. So both of them have the same thing. They both have motor, so your arms can be weak, your legs can be weak, your face can be weak. You can have sensory loss as well. And important small vessel, this is non-LVO, small clots, they can still cause dysarthria or slurred speech. So some people say slurred speech is aphasia. It's not aphasia. Slurred speech, as you know, can be drunk, drug overdose, low glucose, sepsis, infection, urinary tract infection. You know, it can be any of these things that can cause you to have slurred speech. And then large vessel has the same thing. It has weakness and sensory loss and slurring of speech. That's fine. So what's the difference? VAN. That's really the difference between small vessel and large vessel is VAN. You know, you two tend to be weaker as well with large vessel, but not always. But the real difference is VAN. So basically, vision, aphasia, neglect. So for vision, your eyes are forced over either to the right or left. You basically can't look towards one side, or you are completely blind towards one side. So you tell them, look at my nose, how many fingers? 2. They can't name anything on the left. You have 5 hands and they're like 5 fingers. They're like, I don't see anything. I don't see anything, right? So eyes are forced over or they can't see. Aphasia, remember, it's not slurred speech. I'm going to say this 100 times because I think if you know that, you're going to be really good at identifying these. You can't name. So you can't name watch or pen, or this is, I don't know, scrub or microphone. You can't name it. So you'll be like, blah, blah, blah. You can't actually talk, or you can't understand anything. You have word salad. Blah, 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 yeah. I want to go there. Yeah, that sounds great. Yeah, you told me close your eyes and I'm just staring at you. Make a fist. Yeah, that sounds great. Yeah, I can do that. It doesn't make sense. Word salad, right? Which is completely different than I completely understand, but I have slurred speech, right? And the last thing is neglect. Aphasia is usually with right-sided weakness. Neglect is when you ignore the left side of your body. So basically, you may be looking forward, but you're ignoring the fact that you can't move your left arm, ignoring the fact that you're weak on the left, you know. And then the most sensitive way to tell neglect is basically if you touch both the right and you ask them, which side am I touching? You touch the right, they'll tell you right. You touch the left, they'll tell you left. If you touch both at the same time, right and left, you know, they will only tell you right, even though you touched both sides. So they're ignoring you touching them on the left side. They pretty much ignore the left side. All right. And that is basically VAN, vision, aphasia, neglect. It's a mnemonic for cortical symptoms, okay? And here's forced gaze, ability to talk, ability to understand, aphasia, and neglect. And the frontal gaze and vision, I put those under vision, just because it's easier. You're looking at the eyes. So they're like, why does this make sense? How can you be really weak and not have a massive stroke? Is because you see this face, arm, and leg. This all comes together to a tiny little bundle, and it's called the corticospinal tract, or brain to spine. We know that the spinal cord is this big, right? Super small, right? And then, but somehow, right? Somehow this tiny little thing, right, can make you unable to move anything from, you know, half your body or more, right? So if you get a tiny stroke right here, right there, you won't be able to move your face, arm, or leg, but you won't have any van symptoms. You will actually have only face, arm, and leg weakness. You might even have slurred speech if you have motor weakness, but you'll still be able to, your eyes won't be forced over, right? Do you guys see me and the presentation, or just the presentation?
Both.
Oh, good. Awesome. Okay, good. Whew. So your eyes will be looking straight. You'll be super weak. You're like, hello, yes, I'm weak on my right side. You know, I have slurred speech, but I'm talking. So let's do VAN, okay? Yes, one of my arms is weak, but then I don't have vision loss. My eyes aren't forced to the right. They're not forced to the left. I can see 2, 1. I can name, watch, pen, follow commands, close eyes, make fist, and I'm not ignoring my left side or my weakness, right? And so that just shows you that you can have any tiny little stroke here, all the way down to the spinal cord, midbrain, the pons, this is your brain stem, but you won't necessarily have any of the Van symptoms, all right? So word on mimics. So the first thing you do for Van, you have to have arm weakness with one of the Van symptoms, vision, aphasia, neglect. If you have no arm weakness, you're done. So mimics, usually both arms are weak equally, right? So if someone, you see this low glucose, that's why we test for glucose in the field. Seizures, hyponatremia, low sodium, sepsis, infection, anything can give you global weakness. So for Van, the first thing we do is we look for unilateral arm weakness, where the arm is weaker, you know, either the right or left is weaker, right? And that's very important because that'll help you, you know, not over triage, okay? And then, so unilateral arm weakness is super important, okay? And again, the reason why they're like, well, why don't we just use face weakness or a leg weakness? The reason why is face weakness can happen with Bell's palsy. It can happen with minor strokes where the collaterals are so good, where the clot is so small that TPA usually works for. And then leg weakness is basically the blood comes around all the way like this, right? The leg weakness means that you're really bad, you know? So, and lots of times leg weakness will not be involved. It'll only be the arm and the face, right? So the arm is that sweet spot, right? That's the perfect between sensitivity and specificity. And it's the best predictor of large vessel occlusion. That's why the first step in Van, you have to have arm weakness, okay? And this was a study out of Switzerland, which had about 1,200 patients or so, about 1,300 patients. And they looked at National Institute of Health stroke scale. That's the stroke scale they use in the hospitals. And guess what they found? What's the best predictor? Motor arm, not leg, not face. And dysarthria with slurred speech, not good either. Guess what they found the best way to tell LVO is? What does that say? Van, vision, aphasia, neglect. And I put gaze under vision. And in order to do a Van, you have to do arm. So I basically said, I used the best predictors of large vessel occlusion and made it into a scale and a mnemonic. Straightforward, easy peasy. All right. All right. So that's why we use arm weakness as the first step. If you have no arm weakness or you're just globally weak, you're Van negative. You're done in 10 seconds. All right. And then if you have unilateral or one-sided arm weakness, then you test for the Van symptoms. Again, word on mimics and arm testing, you know, you want to have one arm that's weaker than the other, because if you're globally weak, we have to look for other reasons. So part 3, how to do Van. I've kind of already went over it, but I'm going to go over it one more time in detail. Step 1, both arms for 10 seconds. If they have no weakness, they're Van negative. Done, 10 seconds. Thank you, Van negative. If they have both arms and just weak all over, Van negative. If they have one, even if both arms are weak, but one is obviously weaker, then you can test the other things. So the first thing is you have to have one-sided arm weakness. Then you test for vision. Vision, we're looking for eyes that are forced over to one side or the other, right? And what's really cool, I love doing this because it's a trick that everyone loves. And just remember, I can't bear to see my weakness. I can't see that I'm weak. So your eyes gaze towards your side that's moving, your strong side, and it ignores the left side. So the gaze is usually towards the good side. Your vision loss is on your paralyzed side as well. No, I can't see 5, nothing, right? And so isn't that cool? It's like almost though your body's telling you, I don't want to see that I'm weak. I don't want to see I'm having a stroke. So your eyes look towards the good side and your vision loss is on your bad side. So you see your good side and your eyes are moved over. And so that's the first thing. We make sure their eyes aren't forced to the right or left. And then we test their visual field. Look at my nose. How many fingers? 2. How many? 1. Someone that has a visual field cut will tell you, I don't see anything. And this side will tell you 5. Okay. So that's vision, right? So we look for gaze and we look for peripheral vision loss. Aphasia, as I said, slurred speech doesn't count. You have them do two things quickly. Name, watch, pen. Make sure they can talk. Watch, pen. And then have them follow commands. Close eyes, make a fist. Make sure that they can actually follow commands. Again, big thing is aphasia is usually with right-sided weakness. So your right arm is usually weak with aphasia. That's important. And then again, slurred speech is not aphasia. That could be anything else. It could be a small stroke, but not necessarily a large vessel occlusion. Again, none of this is 100%. This is, more likely, less likely. And the last thing is neglect, where you ignore that your left side is weak. And basically that goes with left-sided weakness. And the best way to test it is you just have them close your eyes. You touch their right, they'll tell you, yeah, you're touching my right side. Which side am I touching? And then you touch the left, they'll tell you left. You touch both at the same time, both hands or arms at the same time while their eyes are closed, and they'll tell you right. You're like, okay. And they completely ignore the fact that they're weak on the left. And if you, the most sensitive way is you touch both sides, and they will tell you only right, even though you touch both sides. All right? And so that's basically what the Van exam is. Uneven weakness, then you test for vision, aphasia, neglect. Now, scoring. Need arm weakness with a Van symptom. If you have no arm weakness, or both arms are completely the same, both weak, exactly the same on both sides, you're Van negative, okay? No arm weakness, you are Van negative, okay? You need arm weakness. Arm weakness with normal vision, aphasia, neglect, like that one I showed, you are still Van negative. You need a Van symptom to be Van positive with arm weakness. Van positive, you need uneven arm weakness with a Van symptom. This is a little thing I made. Up in Canada, they simplified Van and called it fast Van. And what they do, instead of also testing visual field where they say 2, 1, all they do is they just look for gaze preference. Eyes are forced to the right or left. I'm fine with, if you want to use fast Van or Van, it doesn't matter. Fact of the matter is you have to test for something under vision. You have to test for full gaze. You have to test something in aphasia. If you only want to have them name, watch, pen, and they can't do it, I'm fine with that. If, following commands, close eyes, make fist, that's, you'll identify more, but these are the minimum, the ones in red. Forced gaze, can't name, and for neglect, ignoring left body. And every scale out there, almost all of them test this. Weakness and basically these cortical symptoms, the vision, aphasia, neglect symptoms. And arm weakness, weakness, severe is if the arm falls right towards the bed, arm to bed, okay? Because it's so weak. And every scale, it's funny, I think I mentioned this in the last one. You can actually get every scale from doing this, right? So there's a scale out of basically Australia, and it's basically they do the same thing. Arm weakness is the first step. If they have severe arm weakness, then they test for vision, aphasia, neglect, with the forced gaze or can't name or ignoring left body. But they use severe weakness because they don't have as many comprehensive stroke centers, and they have to drive an hour or two to bypass. So they want to take like super 100%, this is a massive bleed or massive LVO, and so they basically do Van, but they only take people with severe arm weakness. Again, it depends on where you are and what your county wants to do, but this is basically it. And I wanted you to know this, and just so you have options. This is the screening form we're currently using locally. And side of weakness, you gaze away, right? And the vision loss is on the same side that's weak because you can't look towards your weak side. I don't want to see I'm weak, right? And then aphasia with right weakness and neglect with left weakness. This is out of Canada where they only test gaze, naming, watch, and pen, and ignoring left body. Same thing, just they don't test as much. So doing the full Van, I think, is important because at least in the ED, it can help you identify where the clot is. So if you download the Stroke Van app, you can actually tell where the clot is. There's multiple. There's the superior division, sorry, and inferior division, MCA, ICA, basilar, and PCA. There's all these arteries that can cause a large vessel occlusion. So this person, they called me up. They're like, Mo, I have this patient with aphasia, forced gaze, and weakness of the right arm. Van positive, but radiology red CTA is normal. Do they follow commands? Yes. Is there neglect? No. So none of these in the back of the brain or vision loss were affected, right? So I plugged it into the Van app and it says superior M2 or MCA, the superior division. MCA just stands for middle cerebral artery. And that's exactly where it was. Isn't that cool? Right there. And I no blood flow. I pulled it out and the patient is back to normal, back to talking and back to moving the right side. This is another one with left-sided weakness with neglect and vision loss. So again, if you never test neglect or do visual fields, you would have never picked this up, right? And here it is. Race negative, LAMS, FAST ED, all of them negative, Van positive. NIH scale was only 6, but still, you know, neglect and vision loss is still a disabling syndrome, and I was able to pull it out. So that's basically the Van exam. So section 4, this just quickly, I think all the scales are the same. There's quantitative, adding up numbers, or there's qualitative. Van was the first qualitative where I said, no, you know what, positive or negative. That may be all we need. There's other ones, there's Fast Van out of Canada, which I told you is very similar. And then there's Snow, Ventura scale, they're basically all Fast Van. Alvo out of Japan, Act Fast from Australia, which is basically Fast Van, but they use severe arm weakness. And so there's really qualitative, positive or negative versus quantitative. So I'm gonna open it up for questions, and then we're gonna go over like 5 cases quickly. Do you guys have any questions or concerns?
Your guys' opportunity to ask any questions you have before you take this back to your staff.
Mm-hmm.
So Doc, when people miss something, particularly paramedics or that level of provider,
Mm-hmm.
what's the common thing that throws them off, or what do they miss?
So the reason why I kept on emphasizing slurred speech is not aphasia, that I've seen a lot. So so that's one point, and then neglect. They will sometimes miss neglect, and so just pairing neglect with left-sided weakness and aphasia with right-sided weakness, and I think helps a lot. So just, you know, again, you just give them one example and that's it. Like they know what a drunk person is. They know a drunk person has slurred speech, but they know a drunk person, if you show them a watch or pen, they're gonna say watch or pen. An aphasic person will not be able to tell you that. And so that's the common one I've seen, the slurred speech versus aphasia, and then missing left-sided neglect. And again, the most sensitive way, one, they'll ignore the fact they're weak on the left. That's pretty easy. Or their eyes are forced over, which is forced gaze under vision. Those are easy, right? But the one is where you basically make sure they have them close their eyes if possible, or they touch both sides very hard, and if they only tell you you're touching the right side. So those are the ones that are probably the ones that give some people a little bit hard time. But you know, it's you know, nothing's 100%. So as long as we're catching the really big ones, I think that's good enough. All right. So I'm going to go over these examples, and it just reiterizes these key points. So I have a 44-year-old that came to the emergency department. They have left upper extremity weakness and severe dysarthria, like this. My left side is weak, but I'm talking, okay? I'm not ignoring the fact that I'm weak on the left side. So I don't have neglect. I don't have aphasia, watch, pen, close eyes, make fist. Yes, I'm doing it fine with my right arm. I can see 2 fingers, 1 finger, and I don't have forced gaze. Am I Van positive or Van negative? Negative. Awesome. Why am I Van negative? because I don't have any of the van symptoms. I don't really have aphasia. I don't have vision loss or a forced gaze. I don't have aphasia, and I'm not ignoring my left side or left-sided weakness. I don't have neglect of the left. Perfect. Number 2, here we go. These are real cases, and so lots of them will say they have diabetes, hypertension, all this is because they actually are real cases. So these patients, and you know most patients that have strokes have diabetes, high blood pressure, AFib, are older. You know, not always, because we get young people with dissections or tears that can have this as well, or they have some sort of hypercoagulable state or something. But so 76-year-old came to the emergency department, acute onset of left-sided weakness. The left side is weakness, and they can't say today's a sunny day, and they can't talk. So they have aphasia. This patient would be van positive, right? Because they have aphasia. This was, so usually aphasias with right-sided weakness, but I did have 2 patients over the past 5 years where their speech center was on the right instead of the left. It's rare, but I have to mention it, okay? Most of the time when you have aphasia, it's with the right-sided weakness, but you know, it happens. Again, it's rare. It's only 5% to or less. So here's another one, 82, AFib, chronic anticoagulation, is complaining of acute onset of right-sided weakness, face, arm, and leg. This patient is exhibiting no cortical symptoms. So her eyes aren't forced over. I can see on the right and left. So vision is fine, aphasia is fine. She's able to tell you watch and pen and follow commands, and she's not ignoring her left side of her weakness. So is she van positive or van negative? No van symptoms.
Negative.
Yeah. So cortical symptoms, it means the entire cortex is involved, and when you say cortical symptoms, those are van symptoms as well. All right. Here's another one, 73-year-old with history of high blood pressure, hyperlipidemia, and AFib, not on anticoagulation, presents with right gaze deviation, so the eyes looking towards the right, and left-sided weakness. Exactly, and you notice how the weakness is on the left, but the strong arm is the right, and the gaze is looking towards the strong arm, right? Because nobody wants to look at their weakness, all right? Sorry, I thought that was a cool example. I mean, just all of them are like this. It's just basic neuroanatomy. So this is definitely van positive because, why? Because the gaze, right, which is under vision. So this is what we call insta-van, right? One arm is obviously weaker, and their eyes are forced over towards this side, right? And so some of the EMS crews and the nurses, they're like, Insta-van. They're like, what? I'm like, Insta-van. And they're like, yes, because they instantaneously can see they're van positive. They have one arm that's really weak, their eyes are forced over, or they have one arm that's weak and they can't talk. And so now they're like, Insta-van. Van positive, 2 seconds, you know? And so that's the point. The more you do this, the better you get, where it's boom, boom, it's just automatic. You can just tell these large vessel occlusions within 2 seconds. Again, at first it's not like that. You have to go through the process, but after a while, it's very easy to do. Hopefully, right? All right. This one, left arm weakness and unable to feel both sides at the same time. So you know, the left arm is weak, comes down, and then you tell her to close her eyes. You touch both sides, and she says only right, even though you're touching both sides. Is patient van negative or van positive?
Positive.
Because she has vision, aphasia, or neglect? Neglect. Perfect. All right, here's another one. Acute onset of expressive aphasia. She's following commands. She closes eyes and makes fist, but she can't name, watch, or pen. But the motor exam reveals no weakness at all, none. Are they van positive or van negative? Negative, exactly, because they have no weakness. They can still have a little distal clot, but that's usually too small for thrombectomy, and TPA usually works for that. So if they have an isolated cortical symptom, you know, where it's only vision loss or only aphasia, that usually is not amenable or big enough for a thrombectomy, okay? That's why I always combine, you have to have weakness with a cortical symptom. All right, awesome. Final tips, remember, for vision, can't bear to see your weakness. So your vision loss is on the side that's weak. You can't see anything on your weak side. You can't see anything on your weak side. And your eyes look towards your good side. All right? I can't bear to see my weakness. Aphasia, usually with right-sided weakness. And remember, slurred speech is not aphasia. With these two tips, I think you can get most of them. And then neglect is usually with left-sided weakness. And I think that's it. I'm done. I just wanted to quickly go over the neuroanatomy and you know, the Van exam and give those examples. I know I went through this pretty quickly, but now this allows you guys time to basically ask questions. Wow, clear as mud? Yeah.
I have a quick question.
Yes.
I have a quick question. In respect to the gaze, is it generally a late sign of a bleed? Because from my experiences, I start to see them braiding down. I see the widening pulse pressure. I see irregular respirations. At that point, you know, they're losing everything. At that point, it's like, get to the nearest facility. Is this something that we want, if they are VAN positive, if we're in a rural area, is this something that we want to consider flying someone out with?
I would, because it may even be a bleed, right? And so either way, you're going to want to go somewhere that has neurosurgery or neuroendovascular, you know, neuro-IR or neuroendovascular services, because it's either an LVO or a bleed, especially if they're having other symptoms like that that could indicate that it's a bleed or a large vessel occlusion, because you need that higher level of care of neurosurgery, neuro-ICU, you know, whether it's a clot or a brain bleed.
I can address that question further too.
Yes.
Short answer, no.
Okay.
Because it will not be added to our metrics for automatic launch criteria, and for you guys waiting for your air ambulance out there would simply just delay care.
Okay.
Okay. Yeah, and again, it's all about what is feasible within your region, of course. All right. Other questions, concerns? And again, I mean, I want to go back to this slide because, you know, here, as long as, you know, I'll be honest with you, as long as you do something under vision, aphasia, and neglect, it's super important. You know, if, you know, because just those things have to be tested. You know, if you want to be like Canada and you only want to look for forced gaze and under aphasia, just can't name, watch, and pen, you know, that's, and left side just ignoring the left body, that's fine. But all three have to be addressed. The more things you do, the more things that you will pick up. All right. And again, or you're saying, oh, we're bypassing a little too many people. You can be like us, Australia. We're going to use a modified van where they have to have severe arm weakness. So the point of the matter is, this framework allows you to do whatever you want. If you want to keep your statistics over half a year and say, hey, we're just going to transfer the patients with severe arm weakness that are VAN positive. You know, the point of the matter is, it's here to help you in your region, you know, and, you know, and I've talked, you know, to people in Canada, the US, Australia, whatever works for you, you know. This is just an easy mnemonic I made so people understand what cortical symptoms and a massive stroke is. Thank you, guys.
All right, my name's Chris Neal. I'm an interventional neuroradiologist, endovascular neurosurgeon. Dr. Jaffe and I are the two operators here. He's strolling out the door. What I want to show you are some cases that are from here at DMC. These are not from somewhere else or some other place. These are all cases done in the last 4 or 5 weeks, maybe less. I mean, Brianna, 3-4 weeks at the most. So these are real-time or almost real-time things that are happening here. And this is what a comprehensive stroke center does. I don't know of another hospital for, if you're not comprehensive, most places cannot do the kinds of things I'm going to show you. So let me start with the picture of my team. This is a team sport. I may be able to walk in and scrub and do a procedure, but it isn't without everybody else doing their part. These are my techs, staff. This is a representative image. It's missing a lot of my ball team, but these are the people who are not on call in the trenches at this moment that I could put in the lab. Nurses, staff, techs, my stroke folks. And I wouldn't be in front of you without them. So there are two major types of stroke that we deal with, but they basically boil down to ischemic stroke. And about 25 to 40% are large vessel severe strokes. And hemorrhagic stroke is about 15%. But I'm going to address my remarks for the most part for the next few minutes at ischemic stroke. Ischemic stroke, the ones that you're learning this VAN for large vessel occlusions. These are lesions that do not typically respond to TPA or peripheral intravenous thrombolytics. Some small percentage of them do, but the failure rate is fairly high. So there are two types. And the first type is sort of like you'd see in the coronary arteries, where you have plaque along the walls, soft plaque. You have complement activated, and it thromboses in situ. This is most common in the posterior circulation, but you can certainly see it anywhere. The other type is embolic stroke, which tends to go to the largest vessels. The pipes with the highest flow are going to get clot, typically from the heart, brachiocephalic, but we pull out pieces of broken heart valves and clot and whatever else happens to be rattling around in there that doesn't belong. And most of those things, we have images of some of these, that they will not dissolve with TPA. Most of you have not seen this procedure done. So vascular access, we do a femoral puncture. You probably hear about radial artery access for some things. It doesn't work for cerebrovascular disease. You have to do all 4 vessels from the arch to get in and see what's really going on. If you go from either arm and they have an arch anomaly, or even if they don't, most patients can't be accessed expeditiously from an upper extremity access. For a single vessel sometimes, but not for a stroke case. We typically put a guide sheath from the groin up into the cervical carotid for an anterior circulation stroke, just below the skull base. Sometimes now we have better catheters that go into the skull and sort of lock it down. And then you can see this sort of microcatheter or microsheath coming up, and there's a big clot in the middle cerebral artery here, this cartoon. Here's a picture of my lab without the staff in it. We use biplane imaging, so you can see 2 planes at once. One view is no view in interventional imaging. If I take a chest x-ray and I put a quarter on the front, and you take the picture, you don't know if it's in front, in the back, or sitting in the mediastinum. There's no way to tell. So you have to have 2 views in 3-dimensional space to have any idea of what you're really doing. And working inside the brain is so sensitive, you can't risk it with a single view machine. Let's take a few cases, and these are things that have come through here. Our first patient's a 53-year-old male, presented with right arm and leg weakness, eyes gazing and leaning to the left, and he's aphasic. Last known well was at 2300 hours the night before. It's now 1 in the afternoon when he shows up on my doorstep. He has a history of COPD, hypertension, partial renal failure, probably from his long-standing bladder dysfunction. So let's do the VAN score. VAN weakness? Yes. Gaze abnormality? Absolutely. And he's got aphasia. So, and he also has neglect, but he's a completely full, you don't have trouble looking at a patient like this knowing they need to come in. Patients that appear this way may be a bad bleed. You cannot tell that this is necessarily a large vessel stroke, but because it can be, it's got to be brought to the lab. So here's his perfusion scan. I'm sorry, DMC arrival, we got him at 13:30, so now he's 14 and a half hours out. NIH score 24, it's very high. Right-sided weakness, sensory loss, gaze preference, field deficit, aphasia, neglect. Initial brain imaging. So here's his initial perfusion scan. These are not pretty pictures. Many of the hospitals you will service do not have the ability to do this kind of study. This test actually quantifies blood flow to the brain. So the pictures aren't very pretty. Like this is a fuzzogram if you compare it to a regular head CT, but this area shows an area of cerebral blood flow less than 30% volume, which theoretically represents an area of completed stroke. I will tell you in a hyperacute state, that overcalls everything. That may not be a completed stroke. The area that's green shows a temporal perfusion characteristic of Tmax greater than 6 seconds. That means the time it takes the blood to leave the heart and get to that tissue takes longer than 6 seconds. Normal is about 3 to 4. So we know that that's probably at risk, and that this may well be completed an infarct. And because this area is so large and the mismatch ratio is high, he goes to the cath lab. The carotid artery is tortuous. You can see the guide sheath right at the top. He comes up and there's a stump right here. You see a vessel kind of going posteriorly. You're getting faked out. That's the posterior cerebral artery in a persistent fetal origin. See how big this is? It usually comes off the basilar tip, but in this patient it doesn't. This is the ophthalmic artery. You can see there's a little retinal blush here. But there's no flow to the entire left hemisphere. This is in a right-handed patient, dominant brain. This is one pass, single pass with a retriever, and here we are 10 minutes later. So now you have the anterior cerebral artery open with the A2 segment. You can see the entire pericallosal system is back. The whole middle cerebral artery and candelabra is back. This is what the image would look like without the bone being subtracted. Outcome, 4 days later he was discharged home. NIH score of 5. He still has some cognitive function and aphasia, but most patients with this degree of recovery in just 4 or 5 days, remember our outcomes are determined at 90 days, not a week, he'll probably be very close to normal. This is a 61-year-old that came in from an institution. She was living in a home, dropped her coffee mug, witnessed event. So the time from onset of ictus till the cavalry got there was very quick. Someone called 911. She was being treated for depression, hair abuse, methadone treatment. I'll speak about that in just a minute. Here we go, CPS positive. Next step, Van, weakness. She's got left arm and leg weakness, absolutely. Facial weakness, she has a gaze abnormality and a field cut, so vision, positive. Aphasia, no, she doesn't have aphasia. And neglect, she did have a neglect. So on arrival to DMC, NIH score of 19, right gaze deviation, left field cut, left-sided weakness and neglect. CT contrast, without contrast, you can see a hyperdense MCA sign. I don't know if you've ever heard of this, but sometimes acute clot in the middle cerebral artery can be picked up on a non-contrast head CT. It's not a reliably positive finding. In other words, if you look for it and it's not there, it doesn't mean there's not a stroke there. But if you do see it, it's a high index of suspicion that there may be a clot there. So perfusion scan, once again, you can see there's a very large mismatch, 5.5 times. So she went to the cath lab. Very similar picture, anterior circulation. I do want to show you, there's an abnormality in the carotid artery. If you look here, I want to show you that this vessel is beaded. It's got irregular walls. Normal vessel walls are smooth and straight. This is fibromuscular dysplasia. There's about 5 different types. We don't know what causes it. You didn't do anything to get it. I often see people in the middle years of life with this with panic disorders, psychosocial disease, because since the time they were in high school, they would tell their mom, something's wrong, and they would have kind of a panic attack because some little piece of clot or something would break out of this and go downstream and go away a few minutes later, and no, there's nothing wrong with you. Then they hit the school nurse, and 5 years later, a pediatrician, and they get a head CT, and their workup's continuously negative, but they know something's wrong. It's just nobody can get their head around what it is. These people get put on an aspirin and Plavix for life. So they're also at high risk of intracranial aneurysms. We see more here in the Central Valley than I've ever seen in my career. It's pretty amazing, probably every 3rd or 4th patient. So there's a carotid occlusion. Again, nothing going upstairs. This is a couple of minutes later. Again, both the anterior cerebral artery, middle cerebral artery are back. There's normal perfusion to the hemisphere, no early venous shunting. Couple of remarks about what happens if we don't get this open. So for a middle cerebral artery occlusion that is either untreated or is not reopened, the 30-day mortality rate is 55%. For a carotid occlusion, this is called a T lesion. For a carotid occlusion, the 30-day mortality rate is 85%. So these are big saves when we get these people back. Here's a picture of the cerebral angiogram with the bones on. You can see the before and after and see where the blood flow actually fits inside the brain. Discharged home, day 3, NIH score of 0, no neurologic deficit, complete recovery. So you can see that the perfusion scan overcalled the stroke. There may be some in clinically silent areas, but still, it's a very good outcome. This is a 40-year-old female. I got called on a Sunday evening. And this is a very unusual case. So she has a left-sided weakness, headache, difficulty speaking, last known well just an hour or two earlier. It was like 8:30 or something. She was actually picked up at 1800. History of hypertension, methamphetamine abuse. And it turns out a week later we found out that, or 5 days later, we found out that she'd been transferred to Sacramento. It was medevac 2 years ago for an abdominal vascular problem, but nobody, not even she, could tell us what it was. Stroke scale, she has facial weakness, left arm and leg paralysis, both. Sensory loss, eye gaze abnormality, visual field cut, speech disturbance, and a headache. This is a red flag. Van, of course, she's got weakness, visual cut, no aphasia, no neglect. Still positive. Stroke nurse is on the phone. What do you think? Her NIH score was 13. Yeah, I remember this. Here we go. Visual field cut, and I said, well, she has a bad headache that's been there for a week. And part of the problem when people have a really bad headache is you can't punch through the headache to get an adequate history or even an exam sometimes. So if they're having the worst headache of their life, or a really bad one, you kind of have to step back and go, what's really happening here? So in the face of a headache, I rarely give TPA without an MRI. You know, we're really close to the time window. We've still got some time. I said, throw her in the magnet and let's see what we've got. So here's a perfusion scan, which is negative. So there's nothing to treat her for, but something's clearly wrong. Here's her CTA. I'm going to show you the middle cerebral artery on the right side. Looks really ratty and beat up. I mean, it's still there, but it doesn't look anything like this one, right? This is nice and clean and pretty, and this is abnormal. And there's a big aneurysm here. As soon as I saw this, here's a perfusion scan, no restricted diffusion. Here's the CTA on 3D collapsed images as CT. She has a second aneurysm in the vertebral artery proximal to the vertebrobasilar junction. So there's 2 aneurysms and a bad headache. Well, it's a where's Waldo? Which one's causing the problem? So I go to see her, and what's going on? So while we're getting the MRI, her symptoms go away and her NIH score comes down to 1 or 2. And I'm like, don't give her the TPA. She probably has an aneurysm that's unstable. 3 to 5% of all aneurysms present by embolization of clot. It's just like a patient with AFib. You have a dead space and the heart's not moving, and you get, collection of platelet aggregates and debris, and then you kick it out. Well, now you have a dead space that's a wall of the artery, but it's the same principle. So here's her angiogram 2 days later, after I got her tucked in. Oh, sorry, her headache, when we went to go see her, I said, well, where's your headache? And with one finger, she points to the right eye, the medial canthus, which is right where this is. And I said, okay, that's the problem. But on her initial arteriogram, you can see the MCA now looks normal. That platelet aggregate, thrombus, whatever, spontaneously resolved. We just got lucky. I didn't have to treat it with anything other than aspirin in the emergency department. Here's the second aneurysm, which actually looks worse on the CTA. This is my pre-procedure planning. Translucent 3-dimensional images from our neuroendovascular suite. High-tech equipment. This is looking at the aneurysm and looking down the bore at the neck. You can see it's very large, so I can't just coil this. The first measurements were stents, and this is what it looks like afterwards. The key was not to jail this A1 segment. You can see the stent here and the coils inside. It turns out her hypertension was due to FMD in her renal arteries. My partner actually did a brachial puncture and went down and plastied her right renal artery, and she came off blood pressure medicine. Here's the 3D afterwards. Day 6, she went home with an NIH of 0, her headache was gone, and her blood pressure was back to normal. One of the reasons I think it's important to show cases like that is that everything we get here, we have to take whatever comes in the door, isn't always as clean and pretty as they'd like to have you believe. Oh, it's just an MCA occlusion or a carotid. A lot of times it's the tip of the iceberg of a far more complex of systemic disease. This is a 53-year-old, recent falls, right-handed numbness, weakness, numbness, and vision loss. His last known well at 2300. Again, history of hypertension, diabetes. He has right-sided weakness, loss of visual field, and no neglect, no aphasia. But ataxia. Ataxia is a flag. Does anybody know what you first think of when you see ataxia? What part of the brain? Posterior fossa. Always think about vertebrobasilar disease. It doesn't have to be, but it commonly is. So he's VAN positive. NIH score is 10 with initial acute loss of consciousness, visual loss, ataxia. CT perfusion shows a very unusual picture. You have a small area back here in the occipital cortex of abnormal cerebral blood flow here and here. And then the entire posterior cerebral artery territory, including the medial temporal cortex and part of the parietal lobe and occipital lobe, are showing that they're about to stroke. So here's his angiogram. This is a vertebral artery arteriogram. You can see the skull base is here. Here's the vertebral artery, the pica on the left. Here's the one on the right. And the P1 segment is gone. It's just not there. The whole posterior cerebral artery is absent. It's a few minutes later. We got all this back. Head CT the next day normal. Post-op day 1, NIH score of 1. Posterior circulation strokes, red flags. They're often missed. They're hard to pick up. The NIH score, you can have an NIH score of 0 and still have a basilar artery occlusion, so it's not a great screening test for this. Actually, VAN is better than NIH for detecting a posterior fossa stroke. So diplopia, dizziness, dysarthria, dysphagia. These people come crawling in the ER, horizontal nystagmus. In summary, remember large vessel occlusions, posterior hemorrhagic stroke indicators, last known time well. That's probably the most important thing you can bring us from the field. When was the absolute, to the second, last time somebody saw this person normal, or that they can tell you? And then their severity score. Many of the strokes you'll see won't be large vessels. They'll still need IV TPA for treatment. And I think that's it. Any questions?